You use your periosteal elevator as well as blunt dissection to push it. Don't try to cut it. When you push it, then you will realize that the thick base of the capsule will be there. So there will be a dissecting plane. So you will be easily able to dissect, or you come over the capsule of that joint. So once you push it downward, you just yesterday also I told you just have to take care of the superficial temporal vessels and the branches traveling at the horizontally here. So you just while dissecting it, while pushing it, take care that you don't damage it. If you damage it, then unnecessary while ligating them or while controlling them, you can damage the nerve also. So once you expose the capsule, then try to identify the condyle. How will you identify the condyle? Ask the patient to move the mouth or ask the assistant to move the mouth. Then it is easier. Once you are sure that you are about the condyle, then now you know that this is my arch, this is condyle, and this is the superior joint space. Next. So in this you can see the movement here. Now it is easy. Just along with the arch, this is the glenoid fossa and this is the eminence. So you have to give the incision and you will directly enter into the superior joint space. In the superior joint space, if the disc is not damaged, it will be very easy to identify the disc because this is soft, white and thick layer. So now you remove the disc from the, if it is stuck to the glenoid fossa. Most of the time you will find that it is stuck to the glenoid fossa with the adhesions and all. So take a sharp periosteal elevator and then detach it from the, next. So give us incision carefully. So keeping the blade towards the bone, not towards the disc. So unnecessary, you don't damage the disc. And then next, like this, you detach the disc from the periosteal, from the periosteum of the glenoid fossa and the articular eminence. Once this is detached, and now if you move the mandible, then you will see that you can clearly see the mandible disc. Now, if in the next step, if you want further exposure, you can cut the eminence. This will give you the further approach or further visibility to the superior part of the disc. Now you can see clearly the perforations in the disc or any other abnormalities there. After eminectomy, next. 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 So now we have done the eminectomy. Next. 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 So now this is, if you want to go into the inferior joint space, just palpate the neck of the condyle, remove all the soft tissue from there apart from the capsule, because the soft tissue which is overlying the capsule have lot of blood vessels here. So remove all the soft tissue except capsule, and then this part we do it with the cautery. If you do it with the blade, this is okay, but unnecessary bleeding will be there. So this part just over the neck of the condyle, hardly 7-8 millimeter incision we give with the cautery directly at the neck of the condyle, and then you can use the periosteal.